So you guys all saw the awesome video. Yeah. So what was your differential? What kind of injuries will we be looking for? All right, ligament tears. What else? All right, so lateral collateral, medial collateral. What else? Okay. Okay, fracture. Yeah, so quad tendon. Okay. What else? Okay, just so dislocation.
Maybe like meniscus dislocation.
All right, so meniscal tear, right? Probably. Yeah. You can actually. We'll talk about what a dislocation kind of looks like when it comes to your meniscus. Anything else? So we could keep. I mean, there are probably a ton of other things you could think about as well. So why are you learning anatomy? Why are you spending all this time memorizing this anatomy? Because it's on the test, right? Yeah. That's the answer. But thinking about this, I mean, as you go through medical school, there's usually a reason why you're learning all of these different things. So one thing and the reason we brought a case is we wanted to think about, what does anatomy help you do? Well, one of the things anatomy really helps you do when you come to a patient with a musculoskeletal injury is organize your differential in a way that you can systematically work through those differential diagnoses and say, this is more likely, this is less likely, this is so unlikely, I'm not even included on my list anymore. Right? So we came up with a lot of different things, and we can keep going on and on and on. The problem is if you just kind of write a list that's just kind of straight out of your head, right, and you're just kind of putting stuff on the page, it's really hard then to try to organize that. So one way that you can organize musculoskeletal injuries is just organize them anatomically. So one thing that anatomy really helps you with is just organizing your differential diagnosis. So if we did that, let's think, what are the five, I'm going to use 5 major things in terms of anatomy that is going on in the knee. So what are the 5 major anatomical structures or types of things we have in the knee? Okay, so bone. So I'll say bone. Okay, so we got bone, tendon, ligament. All right, so yeah, I will say from a muscular, well, it's not totally true. I'll say usually from a knee injury musculoskeletal standpoint, vasculature only becomes a really critical in one scenario, which is a little more esoteric, which is if you have a complete knee dislocation, you can rip your popliteal artery. That can become a big problem, and that is definitely vascular. In general, for the purpose of this lab and this exam, I really wanted you kind of focusing on the musculoskeletal stuff because that's kind of what you're learning, and that's when you do physical diagnosis of the knee, that's what you're going to talk about. So that is true. There's lots of other stuff, but so we have bone, tendon, ligament. What else? So yeah, so you could say cartilage, bursa, and I really lump that as joint space, okay? Because all that stuff kind of sits in the joint space, and because when you're doing ultrasounds, especially when you're looking at those types of things, you're really not going to see. You can't see cartilage. You can kind of see the meniscus, but you're looking for joint space effusion in that case. And then the last thing is muscle, right? So those are really, if you think about what makes up a knee, you can think about, okay, well, in my differential of someone comes in and they have an acute knee pain, I can organize my differential by muscle things, ligament things, tendon things. Does that make sense?
Yeah.
All right, so that's why as you think through that thing, okay, well, here are all the ways I can kind of organize that differential. Right. So why do we give you these structures to ultrasound during the lab? And there's a specific reason why we went with kind of choosing those structures for you to ultrasound. Because those are structures that you ultrasound are structures actually very easy to analyze when you're dealing with a knee injury. So I'm going to ultrasound. So we're going to talk through what we just did, and we're going to think about why we looked at those different structures. So we said bony injury, right? So what's the bone that we're mostly thinking about when we think about someone who's got a knee injury? So patella. So okay, so I'm going to look at the patella. Right. So there's, everyone can see my patella there. So what is the patella? Sesamoid bone. What does that mean?
It's like formed inside of the ligament.
So it's inside the ligament, right, or the tendon, right? Why do we need a sesamoid bone there?
Protection of the joint.
Oh, right. So yeah. So that's one thing. So it definitely protects the joint. What else does the patella help us do? What's that?
Does it keep it located?
Yeah, so it keeps it located, right? So if we just had a tendon that was floating around in there and I was doing this, what would the tendon tend to do when it was relaxed? Yeah, it's flop all over the place, right? So one of the things that the patella helps do is when I'm exerting force, right? So when I contract my quad, so there's my quad tendon there, right? All right, it's not my mom's bag. All right. All right.
Your knee feeling all right?
I don't know. We're about to find out.
This is right knee. His left knee is so injured
know.
we can't. Yeah.
Unfortunately, when you are the ultrasound model, you can't hide much.
All right.
Y'all experienced that. Don't tell me. If you haven't, I'll make fun of you. All right.
All right.
Got it?
So we got a patella, right? So he's got his quad and then his quad tendon right there. Okay. So when he tries to extend his tibia, if that patella wasn't there, the tendon you couldn't actually get the tendon to track in that joint space, right? So the analogy I gave last time was if you're trying to lift a car engine out of a car, you throw a rope over a tree, right? And you're trying to pull on that, the rope will slide, not only slide up, back, kind of up and down, but back and forth over the tree, and you get a ton of friction as well, right? So that patella sitting in the patellar groove keeps the tendon on track, but also helps reduce the amount of friction you have when you're trying to flex and extend your knees, okay? So we talked about the quadriceps tendon here. And if we go down here and we do this, we have the patellar tendon, right? So why do I call it the patellar tendon? So you learned it as what? Patellar ligament. Why did the anatomist call it a ligament? Okay, so it goes from the patella. We can actually see it attaching to the patella right there. And then it goes all the way and attaches to the tibia, so it's bone to bone. Okay, why do I call it a tendon now? So what do tendons do?
Transfer force from the muscles to the bone.
Transfer force from a muscle to bone. What do ligaments do?
Bone to bone transfer of force.
Bone to bone. And so primarily what do ligaments help you do? Articulate. Okay, so stabilize, right? Exactly. So when you think about ligaments stabilize joint spaces, okay? Bone to bone, they keep things really tight together. So you're going to learn about the ankle soon, and there are 800 ligaments in the ankle. And you're going to have to memorize the names of all 800 ligaments in the ankle, and then you will probably forget them, right? So why do you get so many ankle sprains? Right? The reason you get so many ankle sprains is because there's so many darn ligaments to sprain in the ankle, okay? You don't strain your ankle, you sprain your ankle, right? So sprains are what? Ligaments. Strains? Muscle tendons, okay? So if you ever, so why do we say, well, I strained my hamstring, okay? But I didn't sprain my hamstring, I sprained my ankle. So sprains are ligamentous injuries. Strains are muscle tendon injuries, okay? So functionally though, if I'm gonna ask him, if his quad is going to act on his tibia, how does his quad extend the tibia?
Pulls on the patella.
So it pulls on the patella pulls on the
Ligament.
patellar ligament, right? So this is functionally a tendon, okay? Because it's a muscle acting on a bone, okay? So that's why. So if he goes up here and he tears his quad tendon, so he tears his quad tendon, I asked him to extend his leg, what's going to happen? He can't do it, right? Because he can't transfer the force. If I ask him, if he tears his patellar tendon and I ask him to extend, is he going to be able to do it? No. Yeah. No, right, exactly. So the patella is going to go up. So if he tears his patellar tendon, the patella is going to go which way? Up, right? So that's called patella alta. And if he tears his quad tendon and we look at his patella, where it's going to be? It's going to be down, right? Okay. So those two tendons are holding the patella kind of in place. Okay. Let's say he fractures his patella and I ask him to extend his leg. Can you do it?
It'll hurt.
It'll hurt. Can you do it?
Yeah.
Why?
The bone is still transferring.
Yeah, because it's a sesamoid bone. It's completely within that tendon. So the tendon still works. Not as well, but the tendon still works even if the bone's completely broken. Okay? That's another reason why, if you think about why is a sesamoid bone, what is the relevance of that? Is it actually doesn't, it doesn't require the bone to be intact to be able to transmit that force. Okay? So those are the ligaments, and that's thinking about the joint. I'm sorry, the tendons. Okay, so those are the tendons. So if I'm going to look at a ligament, so let's say I'm going to look at his MCL here. So here's his MCL. Okay. No, we'll go for that. Probe orientation. That would help. All right. So now I'm going to look at his MCL. So up top we said is femur, tibia, and then you can see that ligament then going between tibia down below, femur up above. Okay, so there's the ligament kind of holding the joint together. What's this thing underneath the ligament there? Joint space. Okay, so what's in the joint space? So synovial fluid, right? What color is fluid on ultrasound? Black. Okay, so there's synovial fluid. So here's our black fluid. Now, why isn't it completely black? What else is in there? What other things are in that right between those two bones on the medial side? Underneath the medial collateral ligament is this other thing.
Synovial membrane.
Yeah, well, there's some cartilage there. What else? What else helps us do this so we don't cartilage? Yeah, what specific? All right, but what other structure? What other structure? You guys told me already though, when you gave me the list of things. Meniscus, right? So that's the medial. So this is the medial collateral ligament. Right underneath is the meniscus, right?
Yeah. You did
This is exactly why we teach ultrasound, okay? Because you guys learned this in a specific way, right? So if I gave you the question on an anatomy test, you'd be able to, you'd know it right away, right? Mm-hmm. But if I give it to you in an ultrasound image and ask you to think in a different way anatomically, your brain, you haven't learned that way to think about it. This is the point of ultrasound. We want you to start thinking about things in a different way, right? So when someone comes in and they've got, I'm looking under here, I'm looking at the medial meniscus, right? How do I know that? Well, I'm looking at the MCL, and I know the structure right under the MCL is the medial meniscus. The medial meniscus essentially is a kind of a sponge. So it soaks up all that synovial fluid, so you don't have a big pocket of fluid in your knee, right? That would be really, if you were walking around with just synovial fluid in your knee, you'd just be squishing all the time. It wouldn't be really efficient for force transfer, right? So this is the meniscus helps you have fluid in your knee, but not just be squishing two bones together all the time. Okay. All right. So that's your medial meniscus. All right. So now we've been able to see. We saw ligaments, we saw bones, we saw joint space, we saw tendons. Okay. So if we're looking for injuries in any of those things, we can actually use our ultrasound not only to kind of identify those things anatomically, but we can look at it and say, okay, well, where are the injuries? So let's just run through a couple of these injuries that we might see. Okay. So the first one is bone. So remember you saw the patella, nice and smooth, right? And if you see a big break in that bony cortex, that's a fracture. Okay? Here's another example of that nice bony cortex and then this big break in between, right? So there's a patella fracture, right? Pretty uncommon with kind of injury that we saw on the video, but someone usually it's oftentimes a direct blow to the patella, but you can get patella fractures. Very easy to pick up by ultrasound. Actually, sometimes hard to see by X-ray, depending on how you do the X-ray. So this is super easy. There's the fracture, right? That piece should be connected to that. Okay. How about tendon ruptures? Okay. So remember, the tendon is supposed to connect. Here's patella, here's quad, and there's the tendon running through right here. Here's our quad tendon right here, and this should attach all the way to the patella here. See this big black splotch right here? Yeah. That's the tear. This is blood sitting in that tendon sheath and around that tendon sheath because this is torn. Okay? So I can look for tendon injuries. Now, tracing the tendon from the quad to the patella, if there's a break in that, it'll tell me, but also big black splotch where it shouldn't be will also clue me in. Okay? So there's a quad tendon rupture. Right? If I have a patellar tendon or patellar ligament rupture, here's my patellar tendon. Okay? Here's my patellar tendon here. This should go all the way up there. And you guys did this on yourself, so now, hopefully, now you see normal, you can start to say, okay, well, there's something abnormal. Here's a big black splotch here where the patellar tendon should connect to the patella. So that's a patellar tendon rupture. Okay, tendon ruptures are really easy, especially superficial tendons are really easy to see by ultrasound. So there's our tendon rupture. So we can assess for tendon rupture. We can assess for fracture. You had what was harder, medial or lateral? The lateral is a lot harder, right? A little smaller, a little more superficial. So you can see lateral collateral ligament tears. You can see medial collateral ligament tears. This is a medial collateral ligament tear. So here's my tibia. Here's my femur. Here's where the medial collateral ligament should be. And you get a sense that there's a big bunch of fluid there, but you can't see that nice medial collateral ligament. So this is someone who's torn their medial collateral ligament. This is the meniscus. So we said meniscus, someone said meniscus dislocation. So actually, what's happening here is essentially what is a meniscus. The meniscus isn't completely dislocated, but it's actually bulging out of the joint space because now that MCL isn't keeping the meniscus in place. So that's the meniscus kind of bulging out there, okay? So ligaments, tendons. What if we wanted to look at joint space, okay? Well, joint space is the place between bones, right? So things that are in the joint space. So blood in the joint space, if you have a cartilage tear or something like that, it's really hard to see those by ultrasound. But you can see fluid, okay? What's fluid on ultrasound? Blood, okay? So what's this? Fluid, okay? So if someone has an acute knee injury and they come in and they have this, what kind of fluid do you think it is? Well, but if they, blood, right? So if they just got a big knee injury, right? It's blood, right? So most of us don't walk around with lots of extra synovial fluid, right? When you guys ultrasound, did anyone see tons of fluid? All right, that would be a problem, right? You can have that, but usually that's a reactive arthritis or infection or something like that. So where am I ultrasounding? So in this case, I'm ultrasounding right here. So if I came up to you and pointed right here before medical school, because after medical school, you guys all, so if I pointed to here and said, what is this? What would you all say? Knee. You'd say my knee. Yeah, you wouldn't say patella. I think most of you would be like, if I said, this is your knee, what is the knee? It's a joint, right? So it's a joint. So joint has joint space. So actually, if I ultrasound right here, and you can see, yeah, we'll switch over. Actually, this is an intact quad tendon. So here's the intact quad tendon. Underneath the quad tendon is joint space. So let's flip back. So Matt's ultrasounding his knee. So let's flip back to, so here's my patella. Here's my quad tendon. Actually, he's got a little fluid in the joint right there. So that's fluid in the joint space right there. See that? Can you ever see that? Fluid? So he's got a little fluid.
Too much weight.
Too much, yeah.
Yeah,
you gotta.
Too much weight.
Yeah. So fluid. So a little bit of fluid in the joint space.
I got tackled by munchkins.
That's right. That was the other left guy.
It wasn't. Oh well.
This is the next injury. We haven't injured you on that side yet. So you can actually now if we come. When I ultrasounded laterally though, I didn't see much fluid. And that's because the fluid's also in this part of the joint, right? The joint is all contiguous. But if we come laterally, we can't see much fluid in that.
I'm trying to see. There you go.
We can't see much fluid here, right? So in the suprapatellar joint space, that's often where that fluid will collect. So here's his meniscus, but we don't see a ton of fluid in that joint space. So sometimes looking in the suprapatellar region, you'll actually pick up those joint effusions a little more clearly. All right. So again, if we're looking, we can look at problems in the joint. So if he's got a lot of blood in his joint, then I start to worry about something going on actually within the joint itself. That can be an ACL tear, a PCL tear, anything else that would rip through tissue and cause bleeding into the joint space. Right. So here's a bunch of fluid in that joint space. Okay? So we can assess the joint really well also. All right, what if we looked at his leg and that's what it looked like? What's that? Blood, yeah, so a big bruise, right? So bruise in the muscle. Well, what is a bruise in the muscle? Blood, yeah. So I can look at the muscle. Now this is a calf, but let's just imagine it was a quad. So here's muscle tissue. And here's a big black fluid in the muscle. So that's a hematoma. It's a collection of fluid within the muscle. You can get a lot of bruising. There's a big black collection of fluid, normal muscle, right? So you can pick up hematomas in the muscle as well. So we can look at muscles, we can look at tendons, we can look at ligaments, and we can look at joint space. Right? All ultrasound helps with all that. Now someone asked me, can we see ACL tears? So the problem with the ACL, and when you dissect the knee, is the problem with the ACL is it sits right underneath the patella, Okay? And we said one of the enemies of ultrasound is bone. So the ACL is protected by lots of bone. Okay? Patella, tibia, femur here. So it's really hard to get to ACL. So we can't see ACL very well. But if we see a big joint effusion in someone who has a good mechanism of injury, that maybe is suspicious. You're going to learn about how to do physical diagnosis of the knee and do all the physical diagnosis tests, varus valgus, anterior drawer, posterior drawer. They don't help you much in the initial first 30 seconds to hour of injury. You think why not? So after he gets tackled, he comes in big swollen red knee, and I said, I'm gonna examine your knee. There's too much swelling, right? So the knee is really swollen. So I'm feeling for ligament laxity in the joint. What's the problem? His joint's really swollen, and so nothing's lax because it's all edematous. What's the other thing is if I try to grab his knee, he's not gonna like that I'm manipulating him, right? So the other cool thing about ultrasound is you can non-invasively assess for a lot of those injuries without having to cause a lot of pain by manipulating the joint. Now, 3 weeks down the line when they're feeling better, that physical diagnosis of the knee works really well, but it just doesn't work quite as well the moment of injury. You're not going to leave here and be experts. I don't expect you to go out and ultrasound someone tomorrow and be able to diagnose all of this stuff. That's not the point. The point of this is to get you to think about how you put all these different pieces together and to use ultrasound to kind of help you put the anatomy with the physical diagnosis you're going to learn and then with the pathology you're going to start to learn. Okay? So it's a tool to kind of help you think about all of those things. When you take your quiz tomorrow and you have some anatomy questions about the knee, this is going to just be a different way that you've thought through that process, and you're going to have a better sense of kind of the knee anatomy. And I promise you, when you actually get into dissecting the actual joint, all of this is going to come back, and you're going to think about that.